Thank you, Dr. Hoffman, for the introduction, and good morning, everyone. Thank you so much for joining us, both in person and online. It's a privilege for me to be here to chair the morning session of this CAUSALab Symposium. And before we get started, I would just like to say a few words about the sensitive topic that we will be discussing today. We're going to be talking today about suicide, which is a major tragedy that in some way or another affects the majority of society. The impact of suicide is far-reaching and long-lasting. The grief and the stigma that accompanies it can follow through families, communities, and generations after each suicide death. Importantly, evidence indicates that suicide is a preventable outcome, which means that advancing our understanding of what works to prevent suicide is a major public health priority. And so that's what we're talking about today. And so without further delay, it is my great honor to introduce Dr. Katherine Keyes, who is going to expand some more context on suicide as a preventable public health problem. So if you'll please join me in welcoming Dr. Keyes.
Thank you so much for that introduction, and thank you, Miguel and others, for the invitation to present today. And thank you for those words about suicide as a tragedy that affects so many families. I just want to acknowledge people in this room who have lived experience with suicide in their own lives and in the lives of their family. It's touched my life as well. I'm a survivor of suicide loss. About 5 years ago, I lost my son's father to suicide. And so that event, even though I've been studying psychiatric epidemiology and suicide for many years, certainly has reframed how I think about suicide as a preventable public health issue. So in my talk today, I'm going to do a little bit of just general background for people who aren't as familiar with the epidemiology of suicide and some of the issues that researchers face when we're trying to designate suicide deaths. And then I'll transition to talking about a few examples from my own work, really focusing on the clustering of suicide in both time and space, and how my research group has been investigating recent trends in how suicide clusters in the environment, as I think it really points to areas for prevention that go beyond individual level risk factors. And I'll end with talking a little bit about the most recent trends in suicide, particularly during the COVID pandemic. So in terms of kind of the definition of what we are talking about when we talk about a suicide death, it's typically described as a death in which the descendant intended to die and implemented the means to die. And that designation of intention is really what defines a suicide death, but also makes it difficult to designate these deaths in terms of public health surveillance and the types of work that we do to try to document trends and risk factors. These designations of intention are often done by a medical examiner or a coroner, and typically, the designation has to be a reasonable degree of medical certainty that someone intended to die, or in the case of a coroner, sort of beyond a reasonable doubt that someone intended to die. And that can sometimes be difficult. Certainly if there is a suicide note that is left, or really obvious information that it was a suicide death, it can be easier to designate. But for a lot of causes of suicide death, it can be much more difficult to know whether someone intended or not to die. And particularly that's been documented in a lot of, and I see that the bottom of the slide is not showing. I have some references at the bottom of these slides supporting a lot of the points that I'm making, but I don't think they're showing up here. So if people want the references for a lot of this work, feel free to email me. But it's written a lot in the epidemiological medical literature about, for example, drug overdose deaths. People with substance use disorders and addiction who are using drugs heavily, when someone dies of a drug overdose death, it's often difficult to tell whether that death was intentional or unintentional. And because of that, we think that, even though per the WHO, about every 40 seconds someone dies by suicide, those are reported suicide deaths, and they're likely to be an underestimate of the total amount of suicide burden across the world. In terms of what we know about suicide death globally, as our kind of conservative estimate of the number of deaths that are designated as suicide deaths, and again, I apologize, there are real references at the bottom of these slides. But about 800,000 people are recorded as suicide deaths across the world, and there's a lot of variation across countries. Among women, the highest rates were in Southeast Asia and South Asia. Those have declined across time from the 90s to now, although the highest rates remain in South Asia for suicide deaths among women. Among men, the highest deaths are, can't see the top of this, oops. But the highest deaths are in Eastern Europe, and there also have been declines in suicide death in Southeast Asia among men as well. In the United States, recorded suicide death really varies across time, and we take the longest time span we can, really going back to 1900. It's difficult to compare those trends over time because the methods to record suicide death and the accuracy of death investigations have really changed over time. But you can see the sort of long time span of recorded suicide death in the United States. In recent history, suicide deaths really declined in the United States throughout the 1990s. And there was this change that occurred in the early part of the 2000s where suicide death really started increasing in the US, peaking in terms of reported death around 2018 in the US. And so this increase is about 30% just in the last 20 years. We've also done some work to further characterize that increase that occurred since 2000 in terms of the age, period, and cohort contributions, because suicide death really does vary across age groups in ways that generate these really important cohort effects. And so there are certain cohorts that carry with them a higher suicide rate through the life course. Shown here are hexagonal maps of suicide death rates among men for firearm and non-firearm deaths, and over here for firearm and non-firearm deaths for women. And we could spend our entire time dissecting these maps. I think they point to a lot of really important information, especially information about prevention, but I'll just focus your attention right here on this cluster of increasingly red dots among firearm deaths for men in middle age. We also see clustering of dots among men in middle age for non-firearm deaths as well, although the strength of the association is for firearm deaths. And that's a really well-documented cohort effect in suicide deaths in the United States that are, we have this group of men who are currently passing through middle age and approaching older age who have carried with them a higher risk of suicide for many years now. I'd also just point your attention to this growing patch of red in younger ages for men. This study stopped in 2018, and when we use these same hexagonal maps, even using the provisional 2021 data, these dots are growing increasingly red. There's this emergence of a cohort effect for young men, and it occurs for firearm and non-firearm deaths, and it's particularly concentrated among men racialized as minorities in the US, including Black and Asian men. And so that's certainly something that's concerning in terms of a growing public health implication. And we see somewhat of the same effect for women, but women have a lower recorded suicide death. So I just want to take a moment, again, as just kind of general background, to talk a little bit about suicide death versus suicide attempts. They have a very different epidemiology in terms of who dies by suicide, who attempts suicide and survives. These are trends in suicidal thoughts, suicide plans, suicide attempts, and suicide attempts that are serious enough to require medical attention among adolescents in the US from the YRBS study. And I just point this out because suicidal thoughts are very common. In US adolescents, suicidal thoughts have been increasing since 2011, but past year suicidal thoughts are upwards of 20%. So a very common occurrence for adolescents to think about suicide and even plan or attempt suicide. But death by suicide is often very different. Thankfully, suicide death is much more rare. than thinking about suicide or attempting suicide. And the people who attempt suicide non-fatally versus fatally are very different demographically. It's much more common among men to die by suicide compared to women, whereas women are more likely to have a non-fatal suicide attempt. What we do know is that suicide is often preceded by a psychiatric disorder, and certainly social autopsy studies suggest that up to 90% of people who die by suicide have a preceding psychiatric disorder, and depressive disorders being the most common. Again, pointing to that place of prevention, that if we really want to prevent suicidal crises from occurring, treating and identifying psychiatric disorders is really one of the most robust public health approaches to addressing suicide globally. The suicidal crisis that can emerge often from a psychiatric disorder or even in periods where a psychiatric disorder is not active are often very short in duration, the actual crisis itself, and the window between attempting suicide and suicidal death is quite short, pointing to, there's kind of this underlying, thinking about suicide and experiencing active symptoms of a mood disorder. When it reaches that crisis point, it's a very short window. And that makes it very hard in terms of public health in order to identify those short windows. And I think that in the presentations that we'll hear today, there's a lot of discussion about interventions that are being developed in order to catch people in that critical window. And what we know from a public health standpoint is when you're in that critical window, access to lethal means is one of the main factors that differentiates someone who survives a suicide attempt versus someone who doesn't survive. Access to a firearm, for example, is a very lethal way in which to attempt suicide, and most people do not recover from those events, and I think we'll hear more about that today. But among people who do recover from a suicide attempt, 90% don't go on to reattempt. So really, in that time of suicidal crisis, reducing the access to lethal means is critical. In the United States, this is in 2020, firearms remain the modal way that people die by suicide in this country, with suffocation or asphyxiation being the second most likely. Both of those ways of attempting suicide are very fatal, very lethal. And so a lot of the public health approaches to suicide prevention have really focused on things like means restrictions around firearms and trying to develop programs so that people who are experiencing mood disorders and suicidal crises do not have access to lethal means. We've done some research on adolescents in the US in terms of the trends over time and how young people die by suicide, and especially for female adolescents who die by suicide. There's been a real increase over time in asphyxiation as a cause of death. And even among male adolescents too, there was really a decline, even though firearms remain the most modal way that people die by suicide in the US, especially young people. There has been an increase in asphyxiation as well. And that really poses a public health challenge because it's very difficult in a non-institutionalized setting to restrict access to means of asphyxiation, and really points to the need to prevent the underlying drivers of the suicidal crisis, because that means restriction is going to be more difficult for methods like asphyxiation. In my own work, and if you could see the references, there would be them, I promise. This is real research. But in my own work, we started thinking about, I've been working with my colleagues in infectious disease and in environmental health sciences at Columbia. And we just started having conversations about the similarities between the work that they were doing in terms of influenza and other viruses, including COVID, and suicide. And if we think about suicide in terms of that classic epidemiological triad of agent, host, and environment, there are a lot of similarities that we can draw on in terms of providing this public health perspective. So a lot of times in psychiatry and in a lot of the work that we do in psychiatric epidemiology, we focus on these host factors that influence risk of suicide death. Things like their psychiatric or disorder history, previous attempts, family history, the kind of triggering stressful life events that people experience in their lives, substance use demographics, etc. But what we've been focusing on in my group more recently at a population level is trying to really identify and characterize these other drivers of population level rates and trends over time in suicide deaths, including what we term kind of agent factors, which is how the media reports on high profile suicide deaths, close contact with a suicide decedent that really drives these small local suicide clusters, and even characterizing the broader environment in which suicide deaths are occurring. We know there's a typical seasonal pattern with respect to suicide deaths, that temperature and altitude make a difference, and that the economic conditions in which young people and adults live and thrive. So I'm going to present to you a few examples from the work that my group is doing in trying to characterize these broader kind of population level trends to understand that space-time clustering of suicide. I'll start by, the observation that suicides cluster in space and time has been made for hundreds of years. This is a book, The Sorrows of Young Werther by Goethe in 1774. It told the story of a young man who had unrequited love. And he was so upset about the unrequited love that he took his own life. This book was immensely popular throughout Europe at the time and led to a clustering of suicide deaths. People dressed like the main character, they took their own lives in the same way that the main character took his own life, so much so that the book was banned in many different countries around that time because of the quote-unquote copycat suicides that resulted from people reading this fictional story. So much so that it's now sometimes called a Werther effect, this effect of exposure to media reports or even fictional stories about suicide that can trigger these clusters of suicide deaths. We know from a lot of reviews and meta-analyses now that the media reporting of suicide death has a major influence on the population level rates of suicide when it's not done appropriately or with care. This is a meta-analysis that was just published 2 years ago with all of these different studies that have been done in many different countries in many different time periods with many different high-profile suicide deaths. And on average, there's about a 13% increase in suicide around the time in which the media inappropriately reports a high-profile suicide death at a population level. My research group, and now this has been shown in other countries as well, has done a lot of work to document this around the death of the entertainer Robin Williams, who died in the United States in 2014. Shown here is the monthly pattern of suicide, numbers of suicide in the US in the years preceding Robin Williams' death. And this is the month that Robin Williams died in the US, and we saw a major increase in reported suicide deaths. And our time series models indicated that this increase in suicide deaths went well above what would be expected given seasonal patterns and given yearly patterns as well. And suicide deaths remained elevated in the US throughout the 6 months following Robin Williams' death. These excess deaths were concentrated in men who were the same age as Williams and who died using the same means. And we estimate in our models that about 1,800 excess cases of suicide were attributable just to the death of this entertainer and the inappropriate reporting that the media did of his death. Moving from those kind of temporal and what we call anomalous temporal increases in suicide death to more localized clustering of suicide death, we've really known for a long time that suicides can cluster in particular areas, especially among young people. Within a high school, within a community, you can have these outbreaks of suicide death that occur, especially among teenagers. And Maddie Gould, with me, who's at Columbia University, has done a lot of the foundational work to really demonstrate that. And we've been trying to, with Maddie Gould and her team, to really see how suicide is clustering spatially over time, kind of taking that idea of the localized suicide clusters and seeing if we can epidemiologically characterize these patterns. So I'll just walk you through what you're seeing here with all these seemingly random dots and lines. So if we focus, these are temporal clusters of suicide deaths by county in the US among young people aged 5 to 25, from 2000 to 2019. So on the x-axis here is year, from 2000 to 2019. Each of these dots represents a suicide cluster. And by that we mean purely statistically, that suicides in counties in the US occurred more frequently than we would expect if suicide were randomly distributed throughout the US spatially. Each of these numbers represents the number of counties that were involved in the cluster. These lines represent the length of the suicide cluster as estimated in our spatial temporal models, and the height of each of these lines represents the strength of the clustering. So if you take this line right here, this is a suicide cluster that comprised 11 counties in the US that occurred between 2004 and 2005. And your risk of death by suicide for young people aged 5 to 25 living in these 11 counties was 4 times higher than we would expect if suicide were not spatially clustering in the US. So that's kind of how you interpret this. And the other thing I should point out is that these lines below 0 are what we call cold clusters. So people who live in these counties had a lower risk of suicide death than we would expect if suicide were not clustering spatially. So a few things emerged from this investigation, and again, if you would like the citation, you can email me. It is published in peer-reviewed literature. But one thing that is really clear is if you look at the clustering of suicide deaths across time, we're just observing more clustering. And actually, if you look at the heterogeneity of the suicide clusters, it is increasing across time. So what that means is that there's an increasing divide between counties with low levels of suicide death and counties with high levels of suicide death. The inequality in suicide death is increasing over time. And it's leading to more and more of these statistically observed suicide clusters. So, the number of suicide clusters is increasing across time. And the other thing that might not be clear from this graph, but is true from what we found, is that the strength of the clustering is increasing. So this overall kind of slope between year and the relative risk of dying in a county with a spatially clustered suicide risk is also going up. So we just have an increasingly concentrated group of counties that have very, very high suicide rates. And those are the counties where we're seeing the biggest increases. In fact, there's about 5% of counties in the US that comprise the majority of the increases in suicide risk over time. And it also racially patterns as well, which we can talk about in the discussion section. I'm trying to be mindful of time. And just to point out too that, not only is, the study that we did of suicide clusters is relatively agnostic to the mechanisms that led to the clustering. But we do know that in addition to social determinants of health, such as county level economic factors and opportunities, that there are physical environmental features of counties that are associated with suicide death, both in the US and globally. This includes things like the ambient temperature, and as global temperatures rise, it's anticipated that there's going to be a profound influence on mental health and suicide. And there's also strong associations in the United States at the US county level in terms of altitude and suicide risk, with very well-known mechanisms. So I just want to end by talking a little bit about the COVID pandemic and what we observed for suicide. I think there was, both among psychiatric epidemiologists and probably a lot of epidemiologists and researchers, there was an assumption that the COVID-19 pandemic was going to have a major impact on suicide. And what we know is that there have been increases globally and in the US in terms of mood disorders, anxiety disorders, and especially kind of subclinical symptoms of psychological distress. And we know those are risk factors for suicide death. And so I know for myself, I was really concerned with what we were going to see in terms of trends in suicide during and after the COVID-19 pandemic. There's just a lot of different mechanisms that we thought were going to increase the risk of suicide death. What we've observed globally and in the United States is really kind of a mixed picture with respect to what the trends have been in suicide during the pandemic. And this is a time series analysis of 33 countries that was just published, I think, about 2 months ago in the Lancet. And so each of these rows here represents a different country. And the green boxes are decreases in the suicide rate during the COVID pandemic. So the US, South Korea, Brazil, England, Mexico, Sweden, all of these countries had actually declines in suicide death during the COVID pandemic. The red boxes are areas where there was an increase in suicide death. So among some subgroups within each of these countries, you do see some signal of subgroups where there was an increase in suicide death, but overall, from most countries that were observed in this analysis of 33 different countries, there were either declines in suicide death, or these white boxes mean that there was really no statistical change in suicide death. That said, there are countries where there was an increase in suicide death, particularly in Japan. We've seen the biggest increases in suicide death during the COVID pandemic. So it certainly suggests that there's a lot of heterogeneity in terms of suicide deaths during the pandemic, and I don't think it's necessarily what we would have anticipated. Certainly I would have anticipated increases. By and large, for most countries, there have been decreases in suicide death, which is good news. We also, and if you were able to see the references, you would know that this is an actual analysis that was published in a journal. And if you could see the top two, would have more information. But I'll just tell you what we did. We looked at Google searches. We were really concerned at the beginning of the pandemic that there's such a lag in terms of getting data on even suicidal behavior, suicide attempts, and especially in suicide death. And using Google searches for suicide-related search terms is one strategy that we can use to try to get a signal in a rapid way. And so, again, with my colleagues in environmental health sciences who use Google search terms all the time for influenza and for other infectious disease, we took meta-analyses that have been done to estimate what search terms are the most reliable indicators of suicide deaths. And we assessed whether those trends in those search terms in the United States, we focused on the US as a whole, and then we focused on New York City, given that New York City had a very early and rapid experience of COVID, burden of COVID. And we saw whether there was, using cross-correlation functions, we assessed whether there was an association between trends in mobility, as documented through cell phone data, and searches for suicide. And really, we didn't observe anything. There was really no signal. There was kind of like a concurrent signal that there was somewhat of a correlation at the same point in time. But in terms of time lags, both the reverse time lag of changes in suicide search terms predicting changes in mobility and changes in mobility predicting changes in suicide search terms, there was really nothing there. And we thought, okay, well maybe the Google data just aren't. Maybe it's too messy, we don't have any information on who's using these Google search terms, so maybe it's just not sensitive enough. And then a year later, when the data came out that there really wasn't an increase in suicide death, and in particular there might have been a decrease in suicide death, we went back to our Google data and we thought, well, maybe actually this was correct and we could have used it, and ongoing we can use it as a marker of more immediate surveillance moving forward. So I will just end there, I showed you the sorrows of young Werther and the picture of the book and the Werther effect that resulted from that. But there's also a well-documented phenomenon in suicide literature called the Papageno effect. And Papageno was a character in The Magic Flute, the opera by Mozart, and much like Werther, Papageno also thinks that he's experiencing unrequited love. And he decides to end his own life. But the difference is that in The Magic Flute, the community members come out and they tell Papageno that his life is worth living and that he doesn't need to end his own life and that he has meaning as a person. And I just want to close with that because it takes all of us, suicide prevention needs to be at the community level, and all of us need to be engaged in the effort to prevent suicide so that we can save lives, both in the US and globally. So I'll just end by thanking some of my colleagues and happy to take any questions as the day goes on. Thank you.
Thank you so much, Dr. Keyes, for that presentation. We do have some time for questions and comments from the audience. Just to jumpstart the discussion, I have one question that I'd like to ask about increases in suicide rates as well as increased clustering at the population level. What are some of the hypothesized drivers of this, and how might you go about investigating those hypotheses in available data?
That's a good question, and now I'm realizing that like I was supposed to think about that before. I would be interested in what other people posit are the hypotheses. Certainly, what's been hypothesized in the literature is these increases in loneliness and disconnection that people have experienced in the United States over the last 10 years, coupled with real changes in economic circumstances and conditions. There's been some research that has indicated that changes in economic precarity across U.S. counties is associated with counties with higher levels of suicide deaths, but doesn't predict what counties increase suicide deaths. But I would say that research is far from being consensus. There's been a couple papers here and there. And so, certainly this kind of interaction of economic conditions and disconnection that some people feel is the strongest hypothesis for what is causing this increase in clustering of suicide deaths in particular counties. Also interacting with other sub-epidemics that have been circulating in the US, particularly the opioid crisis and the overdose crisis. Some of the same counties that are experiencing high levels of suicide death are the same counties that are experiencing high levels of death from drug poisoning. So I think all of those things together are the hypothesized drivers of these clusters. But people who are interested in studying that, please let me know, because I'd love to do more studies of that.
Any questions, comments from the audience? Right here, please.
Thank you so much for your presentation. I was wondering if you could go into the hypothesis of higher incidence of...
Can you use the microphone?
The microphone? Sure. Does this work?
Yeah, that's fine.
I don't know. I was wondering if you could speak towards the hypothesis of increased suicide rates and the temperature aspect piece of the environment. And is there any correlation with like eco-anxiety and the climate crisis?
Sure. So there's the association between temperature and suicide death is relatively well documented, really across the world. Although I should say it does vary somewhat across areas in the world. And there's a number of different hypothesized biological mechanisms about the effect of sunlight and heat on serotonin systems and on mood dysregulation. So I think that those are the predominant hypotheses that underlie this association between temperature and suicide death. In terms of the association with, eco-anxiety and other factors, I certainly don't think that's going to help the association, decline. But certainly I think that as temperatures globally increase and people experience more psychological distress around living conditions and around the social precarity that results from global increases in temperature, that's going to add more risk to already existing risk factor, which is the global temperature.
We have time for one more question, comment right here.
Does suicidal ideation also cluster spatially, or is it just suicide deaths?
Suicide deaths are much, I think, better studied than suicidal ideation. I mean, my understanding is that in general, suicide attempts don't have the same area level correlations of suicide deaths. Part of that is driven by, access to lethal means and how that clusters spatially as well. So I don't think there's as much spatial clustering of suicidal behavior overall, but again, it's much more common. It's about 1 in 4, 1 in 5 kids are going to experience it, so it's just much more widespread as opposed to suicide death.
Thank you so much, Dr.